Okay, hello everyone. So my name's John Goldin. I'm a consultant child and adolescent psychiatrist on the Mildred Creek unit at Great Ormond Street, and I'm also joint specialty lead for the psychological and mental health services. And I'm going to be talking to you today about the systemic response to COVID-19 on the Mildred Creek unit at Great Ormond Street and in North London. And we are going to be focusing on teenagers with mental health difficulties. So in terms of the background, we, as part of the COVID-19 surge planning, we at Great Ormond Street agreed to take paediatric patients from all the acute services in North Central London. There were some big changes happening in a short space of time, and paediatric wards closed at UCLH, Royal Free Hospital, Whittington, Barnet and North Middlesex. And this was to make space for adult patients, essentially. This was back in sort of March time, March 2020, and there was a real concern that adult patients with COVID might overwhelm the system. So paediatric wards were closed. A&Es mostly remained open. However, the system did need to move as much mental health crisis work out of A&E as possible to make space, as I was saying, for COVID patients. So what happened is 2 crisis hubs were developed away from A&E sites in North Central London. One was in the north in Barnet, and one was in the south at the Northern Health Centre in Islington. So lots of young people do present to A&E in a mental health crisis, but they often also have an additional physical health need. So in that sense, they might need an admission to a paediatric ward. For example, if a young person has taken an overdose and needs treatment, for example, for a paracetamol overdose, they often need to be in hospital overnight. And similarly, there is a tendency to admit patients who have tried to harm themselves or kill themselves to a paediatric ward in order to sort of contain the situation and do a proper assessment the following morning when it's less of a crisis situation. So those patients were no longer going to paediatric wards in North London, so they were coming to Great Ormond Street instead in a large number of cases. They sometimes also require a temporary bed while social care or tier 4 inpatient placement is sought. So for that reason too, they needed admission. So there were really a lot of changes that took place in a very short space of time, less than 3 weeks. Feels like a long time ago now, but this was back in March. And I remember going to a meeting with the chief operating officer and leaders from a wide range of trusts and different parts of this hospital, Great Ormond Street. And basically the message was that things are not going to be done as normal. We need to prepare for potentially a large influx of COVID patients in North London, and we need to adapt quickly. So as I say, paediatric wards were closed. Paediatric patients were diverted to only 2 emergency departments at the North Middlesex Hospital and at the Whittington. And we opened up hospital wards at Great Ormond Street to paediatric admissions, to general paediatric admissions. And this service was supported obviously by Great Ormond Street and UCLH child and adolescent psychiatrists. Colleagues at UCLH were Mike Grossman and Jake Ellis, very helpful throughout. And of course, mental health nurses from the Mildred Creek unit. John Forrester led the response from them. And paediatric nurses from Great Ormond Street. They were on a steep learning curve, but they were extremely supportive as well as, of course, the paediatricians at Great Ormond Street, the general paediatricians, Lee Hudson and others. So we occupied the Octave Botner wing. We opened up wards for general paediatrics, as I say, but also for oncology and child and adolescent mental health. Initially, it was at Sky Ward, but then we moved to Kingfisher Ward. But you can imagine there were a lot of changes happening in a very short period of time. And we tried to work out suitable pathways for these patients. And this was pathways within the hospital, within Great Ormond Street, which I and others were leading on, but also linking with the wider sector across NCL. So you can imagine there are a lot of CAMHS services that we were linking with, child and adolescent mental health services across North London, child psychiatrists, different trusts, as I say, Barnet, Royal Free, Whittington, etc. So it was a complicated system. And the pathways, one of which I've put up here, were regularly being updated. So this was a kind of checklist for mental health admissions as of the 1st of May. And basically what it shows is that patients were assessed in the referral unit by the local duty clinician or CAMHS clinician. They were risk assessed, and then there was a decision whether to admit the patient and that was made partly by the NCL child psychiatry consultant, and then they would link with the GOSH child psychiatry consultant. And we were on call 24/7. We did a week at a time as consultants, so it was quite tiring, certainly by the end of the week. But we were felt to be an important part of the pathway in terms of gatekeeping, making sure that the admissions were safe to be transferred, and that there was adequate nursing and so on. I mean, we did have a policy of basically saying yes to everything, but we did need to make sure that it was safe. So the local child psychiatry consultant would contact us as the GOSH child psychiatry consultant. We would link with the bed hub. We would link with the general paediatricians, because the patients actually came in under the general paediatricians as they would on a general paediatric ward in the home hospitals. The bed management hub were crucial for the whole process, and they were very helpful. And if we didn't have sufficient nurses, or some patients needed 3-to-1 support, some of them were aggressive, some of them were at high risk of absconding, then we might need to look at alternative options until we could get adequate nurses in. That didn't happen very often, but it did happen on occasion, and it was important that we could gatekeep to make sure that admissions were safe. But by and large, we said yes. Patients were rapidly admitted under the general paediatricians, and then were cared for as appropriate. So what did we do well at GOSH? Well, we created additional bed capacity for short stay admissions. This was done in a very short period of time, as I said. This bed capacity was made available to the whole NCL system. So they were coming from quite far afield. Sometimes they were coming from as far away as Edmonton, from North Middlesex. They would come in under the general paediatricians, as I said, with support from PAMHS psychiatrists, both UCLH psychiatrists and GOSH psychiatrists, and mental health nurses. So we did have this very carefully thought through pathway and system. It was very collaborative and coordinated, and I think people worked really well together. The MCU, the Mildred Creek unit, we provided beds if mental health inpatient admission was needed, and we had quite a flexible approach. So normally our age range, for example, on the MCU is 7 to 14, but we were admitting 16, sometimes even 17-year-olds. So we really were very flexible in a way that did make some people feel understandably a bit uncomfortable. And we also admitted patients quickly without sort of the normal full assessment that we would do prior to admission. But we were, operating in unusual times, and I'm very proud of the way that the MCU team and the wider team as well were able to respond. The paediatricians, the mental health nurses, etc. So there was extensive work, obviously, with the wider NCL system to make the pathways work. We had regular meetings with them. I remember every Friday lunchtime was an hour-long meeting via Teams with a broad section of NCL staff, leaders from the different trusts, and Sally Hodges at Tavistock chaired those meetings. But it was really quite a complicated process linking up everyone in the way that we were able to do. We had to link with the CQC to register GOSH to accept patients under the Mental Health Act. So I remember Matt Shaw was involved in a conversation, I think it was on Good Friday in the evening, contacting the CQC to make sure that we could take patients under the Mental Health Act, because GOSH has not typically been set up to do that. But in this case, we absolutely had to be able to do that, because patients were unwell enough to need to take detention sometimes for their own safety or for the safety of others. So we were able to be flexible about that, and the CQC were able to register us. Mostly patients, I think, had a positive experience. We had regular huddles every day, 2 or 3 daily huddles, representing all the teams involved. And it was a dedicated mental health ward for crisis admissions, and it really was staffed by skilled mental health nurses and psychiatrists with effective collaborations. Some of the difficulties were that patients needed transfers from A&Es to GOSH, and obviously that was quite a process, particularly if a patient was aggressive or reluctant to come to GOSH. And making sure that the right transport was used and the right staff to support that transfer was sometimes an issue. It was really intense crisis work. It was ongoing. It felt a bit unrelenting at times. There was a challenging clinical workload. Some staff felt quite overwhelmed. Staff were working outside of their comfort zone sometimes. MCU staff working in a more acute paediatric setting. Paediatric staff working with quite seriously mentally unwell patients. There was a bit of a risk of burnout in some cases, but by and large, people really managed very well and supported each other. There weren't alternative wards available, so the directive was to always say yes, essentially, and that put people under a certain amount of pressure, but was necessary. We got staffing, nursing staffing, sometimes from bank staff, but sometimes the expertise wasn't quite as good as we would have liked it to be. There was variable contribution from some teams and trusts. So some trusts lent us their staff, as it were, and because we were taking patients from their trust, staff came to work at Great Ormond Street. Other trusts perhaps were a little bit more reluctant to do that, partly understandably because they were obviously under pressure locally, but that contribution was a little bit variable. I think over time, collaboration gave a little bit way to competition, and it's a longer conversation than I've got time for now, but there is some competition between paediatric wards in North London. The Royal Free has actually closed its paediatric ward since this happened, which has been an issue that's been around for a number of years, whether the paediatric wards need to be rationalised. And I think some of those across North London, I think some of those wider system issues contributed to a sense of competition at times. When we did close Kingfisher Ward, it was in July 2020, and there was little preparation or clear planning really for it. There was some warning that it was likely to happen, but it did happen very quickly when it actually did happen. And that was really a decision from the CEO in discussion with other CEOs about what we were able to continue doing with the staff that we had. Of course, use of PPE, masks, social distancing was an issue. We're all much more used to that now than we were at the time, but we had to adapt. The MCU structure was certainly challenged, with older adolescents being admitted with little notice. And of course, technology was an issue too, with MDT meetings, sort of hybrid meetings taking place, some people being there in person, others via Zoom. Lots of technical challenges that I think we're a lot better at now than we were a few months ago. There was a whole range of clinical presentations, quite severe presentations, severe self-harm, high-risk suicide attempts, very significant trauma, sadly. And of course, this was partly during a period of lockdown. So when the family environment is a difficult one, a lockdown is particularly difficult, as you can imagine. There are situations where there's abuse in the home environment, there's safeguarding issues, there's conflict, verbal or physical conflict. So some family environments are far from ideal, and young people are caught up in that situation, and then they're often the ones that need admission. Things get exacerbated. Eating disorders, when they present early, they're more treatable, but often they were presenting later because of the lockdown and because people were reluctant to go into hospitals and thought services were closed. So eating disorders, we noticed a sort of spike in more severe eating disorders, psychosis, neurodevelopmental conditions, and challenging behaviour. So a range of clinical presentations. This is some data from Skye and Kingfisher Ward that I'll just go over briefly. We admitted 39 patients between the end of March and mid-July, and the average age was about 15. The length of stay was about 3.9 days, so we were able to keep the length of stay short, ranged from 0 to 13 days. 26 of them were voluntary admissions and 13 were detentions under the Mental Health Act. Most of them did come via the Whittington, and most of them needed one-to-one supervision, but there were 3 patients that required 3-to-1 supervision, so you can imagine they were pretty disturbed and challenging patients. There were 9 episodes of restraint, 4 episodes of sedation, rapid tranquilization. There were 3 readmissions, and in terms of discharge, 20 patients were discharged home and 11 were transferred to Tier 4 inpatient psychiatric units, such as the MCU or Simmons House or the Beacon in North London. And others were discharged. One was to social services, to accommodation, and a couple of other places, but most were discharged home.
In terms of the range of interventions, there was quite a wide range of things we did on Kingfisher Ward. In terms of therapeutic interventions, there was nursing input from both mental health nurses and paediatric nurses, psychiatric input from GOSH psychiatrists and UCLH psychiatrists, as well as other CAMHS psychiatrists, family work, social work, etc. We did use the Mental Health Act in a number of cases, which was necessary to protect the young person involved, sometimes to protect other people as well. Restraint was used on occasion. 2 or 3 young people needed 3-to-1 nursing. So there were some quite severe cases of young people wanting to abscond or harm themselves, or being aggressive to others, needing as much as 3-to-1 nursing. So that was, as I say, to manage violence, sometimes to keep safe, and sometimes to feed them via NG tube for some of the young people with severe eating disorders. Pediatric links were crucial, and we did do lumbar punctures, MRIs, EEGs as needed in conjunction with our pediatric colleagues. It was a place of safety for many young people. Home maybe did not feel safe. Being outside of hospital was not safe. So it was a kind of place of containment for them until things felt more settled or they were able to go elsewhere. We needed to link regularly with the network and outreach teams, community CAMHS teams. That was a very important part of the process. We did aim for short admissions, and this was mostly achieved. The maximum length of stay was only around 11 days, most admissions, which is 2 or 3 days. And they were either discharged back home, or in some cases they were transferred to a Tier 4 adolescent psychiatric unit or children's psychiatric unit, which very much included the MCU. On the MCU, we were, as I said, significantly more flexible around our age range and able to admit very rapidly as needed. In terms of the mental impact on the mental health of young people of COVID-19, many young people have been missing out on school. They've been missing out on education and social opportunities. They're quite socially isolated. It's pretty hard to be a teenager in lockdown with fewer opportunities for play or recreation. They're very anxious and understandably frightened of infection, either for themselves or for other family members, or they're worried about close family members getting unwell, maybe grandfathers or grandmothers, frightened of death in people close to them, or illness. And also in lockdown, young people are obviously not able to go out in the way that they normally can. So they're stuck in their home environment. Many home environments are very helpful, and some families have talked about enjoying more quality time together. But some home environments, sadly, are quite abusive environments. There may be domestic violence or abuse of other sorts. So unfortunately, we've seen more risks associated with that, and some of the young people that were admitted to Kingfisher had very difficult home environments. There has been reduced access to face-to-face CAMHS support. There's been much more remote working with CAMHS, which has been a big plus in some ways of the pandemic, that more remote working has been used and we're more flexible about that. But in some young people do need that face-to-face support, and that's been harder to access. And in terms of the surveys that have been out there looking at the impact of coronavirus on the mental health of young people, there have been a range of surveys and research is ongoing at the moment. But one study from March 2020 showed that 83% of young people with existing mental health disorders experienced a worsening of their symptoms with coronavirus, with the coronavirus pandemic. This also had a significant impact on CAMHS professionals. So we've done some major reorganisations, for example, what I've been talking about in this talk. We needed to be very flexible at Great Ormond Street. There was a policy of always saying yes. Some staff have needed to self-isolate, have been unwell, have been working from home. Sometimes doctors and nurses have felt somewhat split from other members of the multidisciplinary team. The doctors and nurses have often been the ones that have needed to come in face-to-face, particularly the nurses. It's very hard to be a nurse remotely, whereas other MD team members are more able to do their work from home, offer therapeutic sessions remotely and so on. There have been more telephone and video appointments and meetings, which, as I say, has been a good thing in some ways. That flexibility certainly progressed things very rapidly in terms of staff being used to using things like Zoom, platforms like Zoom and Microsoft Teams, etc. There's been a really good collaboration and cooperation for much of the time, but there's also been, at times of stress, people need to look after their own services as well and their own resources. So that has been a challenge sometimes with, more patients coming to Great Ormond Street and not necessarily the staff following them from some of the hospitals around us. There have been very intense workloads for many, but perhaps even for some people at certain points there's been lighter workloads. But I think for the vast majority it's been a pretty intense time. In terms of working from home, there are obviously some boundary issues. You know, there's more overlap between your work and your home life. We've got to know each other's pets. People have been looking after their children at the same time as trying to work. People are checking emails more, I've noticed, sort of early in the morning and late at night. So this has been a challenge perhaps for many staff and patients as well. And I think it's also fair to say that there are different thresholds and perceptions of risk between professionals.
So just to conclude, in terms of future plans, we did have an external review by the NCL STP PAMHS in May, and that gave really positive feedback and some helpful recommendations. You can see that the team were extremely impressed with the amount that had been achieved in a very short space of time. We did close the Kingfisher ward in July 2020 because staffing wasn't made available to sustain it, and future plans now are uncertain. Some paediatric wards have reopened in the NCL sector, and there are some closures as well and reorganisation, as I mentioned, and there is currently a second wave, and we're collaborating in an ongoing way with the NCL network as appropriate. So that was a bit of a canter through what we did, but thank you very much for listening.